saying, I think it always rains on Wednesdays, or snows, or ices. So hopefully we'll get spring sprung soon enough. Dr. Island, yes, is here to speak with us, and he's from Mercer Medicine. And we're talking this month about heart health because February is National Heart Month. And I know a lot of you guys took the heart quiz and did the heart walk and all kinds of good things. So I hope that you continue those healthy heart habits, ooh, that's tough to say, throughout the course of the year. And I think he's going to give us even more information from a physician standpoint about things that we can be doing and things that we need to be aware of. So please join me in welcoming him, and he'll be happy to take questions at the end. So thank you, Cath.
Thank you guys for having me. I appreciate it. I tried to make this a broad topic to appeal to people who are medical or people who are scientific and people who are not so scientific. So hopefully it'll appeal to everybody. We're going to talk about understanding atherosclerosis. So to start with, today we'll talk a little bit about understanding the development and the progression of atherosclerosis, understand some symptoms and complications, paying attention to sex-related differences, understand some preventative strategies, and dispel some common myths and misperceptions. The NIH defines simply atherosclerosis as a disease in which plaque builds up inside your arteries. Arteries obviously are blood vessels that carry oxygen-rich blood to your heart and to other parts of the body. And plaque is essentially a substance of fat, cholesterol, calcium, and other substances that's found in the blood. And over time, this plaque hardens and narrows the arteries. This can limit the flow of that oxygen-rich blood to your heart, to your brain, to other parts of the body, and can lead to serious problems including heart attacks, strokes, and even death. The prevalence is shockingly high. 80 million Americans have cardiovascular disease of some sort, and 1.25 million people have heart attacks every single year. Worldwide, cardiovascular mortality is pretty high. It depends on where you are in the world, what percentage of death is related to heart disease. When you look at Eastern Europe and Russia, it's 58% of deaths are related to heart disease. Whereas in sub-Saharan Africa, where infectious diseases are much more common, it's down to around 8%, 8-9%. In America and in the high-income Western countries, the average heart disease-related deaths is 38% of all deaths in those countries. The good news is that's actually reducing. On the left, you see, on the upper part here, you'll see that in the high-income countries from 1990 to 2001, the percentage of deaths related to heart disease went from 45% to 39%. And in America alone, you see where all the deaths peaked around 1960, they're all starting to come down. So we are making some progress. So this is the classic diagram of how atherosclerosis progresses. And despite common beliefs that it's only in your 40s, 50s, 60s where this happens, this can actually start in your first decade of life, where you get your initial very first development of fat in the arteries that leads to what's called a fatty streak in your second decade of life. So even in your teens, early 20s, you can start to develop these fatty streaks that over time, up into the fourth, fifth, sixth decades of life, where you get these, it's called atheromas, or big collections of plaque, as we talked about, that can rupture or erode or cause other problems that lead to heart attacks and strokes. So this is not something that happens very quickly. This happens over decades and decades. This is how it looks in real life. On the right, you see a normal artery. This is the aorta that's been opened up in half so you can see the inside of it. On the right, you see it's very clean and smooth. It looks very, very healthy and normal. On the left is someone with bad atherosclerosis, where you can see it's pock-marked and red and inflamed and quite ugly. And you can imagine pieces of that flipping off and obstructing other vessels and causing lots and lots of problems. So what are the causes? We know lots and lots of causes. Everybody's heard about them. We'll go over them in a little bit more detail. There's two types. There's the non-modifiable and the modifiable. Obviously, you can't change your age. You can't change, your genetics. It's hard to change your sex. Modifiable risk Modifiable risk factors, we'll go over these one by one. So smoking, of course, is the most important modifiable risk factor for heart disease. It accounts for about 450,000 deaths annually. 35 to 40% of those are related to coronary heart disease. If you smoke a pack or more a day, your risk of developing heart disease increases by 2 to 3-fold, or 200 to 300%. Okay? This is dose dependent though. So even if you smoke 1 to 4 cigarettes a day, your risk is still increased. And in young women who are on oral contraceptive agents, this risk is compounded. What happens, it increases your blood pressure, it reduces oxygen supply to the heart, it can damage the artery's ability to regulate itself and to flow within itself, and it converts bad cholesterol to an actual worse cholesterol, an oxidized kind of cholesterol. Once you quit smoking, your risk immediately starts to decrease. By 1 year, the risk of heart disease, or the increased risk you developed of heart disease, has been decreased by half. By 15 years, your risk is the same as somebody who's never smoked. So there's good news, silver lining in that as well, is that your risk can be reduced. Death from coronary heart disease is reduced by 1/3 of people who quit compared to those who don't. In other words, if you already have heart disease and you quit, you're much less likely to have problems. And the people who already have heart disease, quitting smoking reduce your risk of sudden cardiac death, recurrent heart attacks, and death from other chronic diseases by almost half. And in communities where they've initiated smoking bans in public places, when they measure, the heart rates have dropped precipitously even in the first year of those bans and have continued to go down. Hypertension is probably one of the second most common. 50 million Americans have high blood pressure, and the incidence is actually increasing. Unfortunately, the worst part of it is 1/3 of patients, or 1/3 of people, don't even know they have high blood pressure. Pre-hypertension is defined as a systolic blood pressure of 120 to 139, or diastolic blood pressure of 80 to 89. Depending on other risk factors, you may be more aggressive in treating it, may not, but it still does increase coronary heart disease even if it's not treated, regardless, by 2-fold. The official hypertension is above 139 and above 89, and most times medication is needed. Exercise and sodium avoidance is always recommended, but the studies on just doing lifestyle changes have been disappointing in reducing hypertension. So most times medications are needed. And the good news again is if you reduce the high blood pressure, you actually do reduce your risk. This diagram shows the difference in blood pressure, so the drop in blood pressure, and the risk of bad things happening. And when there's no change or it goes up, then the risk is still very high. As it comes down, your risk comes down, down, down. High cholesterol, or hyperlipidemia. 45% of all U.S. adults have high cholesterol. It's cholesterol above 200. The bad cholesterol is called the LDL. And the good cholesterol is called the HDL. There's more than that, but those are the basic ones. And for every 1 point of increase in your LDL above normal, you have a 2 to 3% increase in coronary heart disease. So most people don't just have a 1 point increasing, that's 20, 30 point increases, so that is exponential. And for every 1 point decrease in the good cholesterol, you have a 3 to 4% increase in coronary heart disease. So obviously, a lower good cholesterol is even worse than a high bad cholesterol. And diet and exercise, although are helpful, medications are a lot of times necessary. Obesity, we all know we're in somewhat of an obesity epidemic, and these rates have doubled over the past decade. It's estimated that now 30% of U.S. adults are obese. There is some controversy, though, as to whether obesity is actually a risk factor for heart disease. It's not clear whether obesity itself is, or it's just some of the complications of obesity, such as lack of exercise, diabetes, high blood pressure, and elevated cholesterol. It's not quite clear if just being overweight is additive above those other risk factors. But studies have shown that even as little as 30 minutes of walking every single day, regardless of weight, has significant CV benefits, cardiovascular benefits. So you don't have to run, don't have to be doing competitive swimming. Just a 30-minute walk every single day is helpful. And one thing my patients always tell me is, hey, I walk all the time at work. I'm running at work. And I always have to tell them that doesn't quite count. The 30 minutes is a 30-minute continuous walk. A lot of times you're working, you stop, bend over, do something, start walking again. So that it's a 30-minute continuous walk that really helps. Diet, of course, we need to talk about. The American Heart Association recommends you reach and maintain an ideal body weight, easier said than done. They recommend a well-balanced diet of fruits, vegetables, and whole grains, and limited sodium, limited saturated fats, and refined carbs. The percentage that they recommend is this circle graph we have here, where they say 20% protein, 45% carbs, 28% unsaturated fat, and 7% saturated fat. Carbs, as we all know, there's a wide amount of carbs. It's not just the breads and the cereals and the pastas. It's also fruits and vegetables and yogurts, things like that. There is a difference between good carbs and bad carbs. I stole this slide, but good carbs are things that have lots of minerals and vitamins, more fiber, low glycemic index. Bad carbs are things with very low fiber nutrients, more refined sugars, and a high glycemic index, such as white breads and sugars and cereals and sodas, candies, obviously. Proteins, we all know, come from meats, fishes, red meats, chicken, but it also comes from beans and from nuts. And the bigger area we really start talking about with heart disease is the fats. There's two types. There's the saturated fats and the unsaturated fats. The saturated fats are things like milks, bacon, fatty red meats, eggs, cheeses, butters. Okay? The big thing that's kind of being talked about right now is the coconut oil. And I want to just point out the saturated fat is the bad fat. That's the fat that increases the risk of heart disease. And when you look at coconut oil versus, say, butter, which everybody has heard a million times, don't eat too much butter, it's bad for you. First thing to notice here is the serving size of butter is twice as much as the serving size of coconut oil. So every number I give you here, we've got to multiply by 2 to compare it to butter. So the total fat in the coconut oil is 14, so 28 grams compared to 5 grams in butter. The more important is you look at the saturated fat. The saturated fat per serving is 13, so really we'll say 26, whereas it's 2 over here in butter. And there's very, very little unsaturated fats, which are the better fats. So coconut oil is essentially tons of saturated fat. That's really all it is a big bunch of saturated fat. The unsaturated fats are things like salmon, avocados, nuts, olive oil. And these are the better fats for you. Now, everybody has their opinions, but I'm going to prove it to you, hopefully. Yeah. So there's a diet called the Mediterranean diet. Now, this isn't a diet for losing weight. This is a diet for heart health. There have been quite a few studies that have been done on different diets. There's one study that compared Atkins diet and Dean Ornish diet, low-fat diets, and they all were pretty much the same. There was really no difference in any of them, even compared to a standard diet. The Mediterranean diet is a diet that's high in total fat, but it's very limited saturated fat. So almost no saturated fat, all unsaturated fat. It's very high in the intake of olive oil, fruits, nuts, vegetables, and cereals, a moderate intake of fish and poultry, low intake of dairy products, red meat, processed meats, and sweets, and wine in moderation. Moderation is not defined. So the study I want to prove it to you with is called the Lyon Heart Study. And it basically compared a standard low-fat diet to the Mediterranean diet for the risk of heart disease. This was a primary prevention study, meaning that nobody in this study had heart disease already. Okay? They did a secondary prevention study, but that's a talk for another day. For primary prevention patients who had no heart disease, it was a large study. There was a significant reduction. You can see these curves are very, very different here. Hopefully it shows up well up there. Between the control group, where they had much higher incidence of death, heart attacks, strokes, than the people who were on the Mediterranean diet. They did multiple different composite endpoints of all sorts of different things, threw all sorts of different problems in there to see if there was a difference in every single outcome. The outcomes were better, which has not been shown really with any other diets. So on to diabetes. People with diabetes have a 2 to 8-fold increase in coronary heart disease when compared to age and ethnically matched non-diabetics. And 75% of all deaths in diabetics is related to coronary heart disease. So it's a big problem. There's also, this notion of prediabetes. And the problem with prediabetes is, even though you may not need medication for the diabetes at that point, you still have risk of heart disease that's developed. So in the Nurses' Health Study, they followed nurses for a long time, and they looked at nurses who were eventually diagnosed with overt diabetes, and saw that their risk of developing heart disease was 3 times that of people who didn't develop heart disease. So even before that happened, even before they were officially diagnosed. So what that means is that prediabetes has almost the same risk associated with it as overt diabetes. Controversy exists over what goals to use to treat diabetes to reduce risk. Currently, the recommendations are an A1C less than 7. A1C is a marker of how much sugar's attached to your blood cells. And that's currently the goal. We don't know what's the best goal, honestly. Stress and depression both have associations with heart disease. Both chronic stress and depression will increase your risk of heart disease. And acute stress has been associated with acute heart problems, not necessarily heart disease, that there is an increase in heart attacks, but other heart problems as well. So how do we know if we have heart disease? Some of the symptoms to look out for are what's called angina. It's a chest pain or discomfort. It doesn't have to be a sharp pain. It's a lot of times a pressure or a heaviness. Sometimes described as an aching or a burning, a numbness, fullness, or squeezing. It can radiate to the left arm, the shoulder, the jaw, the neck, very commonly. It's also a lot of times associated with difficulty breathing, palpitations or feeling like your heart's flipping and flopping and skipping, a faster heartbeat, dizziness, nausea, extreme weakness, and sweating. Women create kind of a challenge, as their symptoms are not always the same as men's. Frequently, they are not the same as men's. The classic crushing chest pain is not what women typically present with. It's more shortness of breath, weakness, unusual chest pains, unusual fatigue, also nausea, vomiting, dizziness. Can sometimes get a lower chest discomfort or upper abdominal pressure and back pain. As I said, many women do not have the typical, what you see on TV, the man clutching his chest. You can learn some more on the web if you like. The U.S. Department of Health and Human Services has lots of information. The NIH has lots of information on subtle and dangerous signs of heart disease, especially in women. And the National Diabetes Information Clearinghouse has lots of information on diabetes and heart disease. So if you think you have heart disease, how would we figure it out? Well, obviously the first thing you go see your healthcare professional, who would talk to you about your medical history and family history, look at your risk factors, and do a physical exam, some diagnostic tests, and possibly procedures. There's lots of blood tests. We won't go into these in detail. We can do biomarkers to see if you've had a heart attack. We can look at blood cholesterols and different kinds of lipid testing, as well as look for signs of inflammation and other problems. First thing that'll usually be done is an EKG, a bunch of stickers on the chest, and we'll measure the electrical activity going through the heart in different areas, and it can give us clues as to if there's a problem. Even if it's normal, however, that doesn't rule anything out. So sometimes we have to move on to stress tests and echocardiograms. Stress tests there's different types. The classic is you walk on a treadmill while you're monitored on EKG. And sometimes you do nuclear testing or an echo with it to look at the wall's perfusion, or the amount of blood getting to each wall of the heart. But we can also do it, if you can't walk on the treadmill, we can do chemical tests instead of having you walk. An echocardiogram is an ultrasound like they do with babies, but you do it on the heart, and you can see how the walls move, how the valves move, and get lots of helpful information on how the heart's functioning. More aggressive testing includes CT scans. You can do CT scans of the vessels of the heart, the structure of the heart. And finally, the gold standard is coronary angiography, or heart cath. This is how a heart cath looks. So I can get my cursor up here. So this is the catheter here that we place into the heart arteries, and we inject a contrast through the arteries and take x-rays. And if you look here, this is a nice fat artery that's coming down the side of the heart. And then right here, you see it gets very, very skinny. It's fat most of the way down, and then it gets real, real skinny where that cursor is. And that is coronary artery disease. That is a narrowing of the heart artery, and that's a severe narrowing. That's probably 99% there. And you would treat that most likely with a stent. What a stent is basically a metal scaffolding, and it's put in by traversing a small, very, very small wire down the artery, and then you track a balloon down the artery as well on top of that wire, and the balloon is deflated and has the scaffolding squeezed down and crimped onto the balloon. You position it right in the right spot, and then you blow up the balloon. And when you blow up the balloon, it expands the metal scaffolding, pushes all the plaque out of the way, and when the balloon comes down, the metal scaffolding stays. And you can see down the bottom picture, now the lumen is restored. It doesn't take away the disease, it's just a plumbing. It just fixes the plumbing so you get good flow. Okay? So all the other things are important. All the medications and the rest of the things, the diet, are all important. This is just to treat symptoms. The other procedures they can do is called a bypass surgery, also nicknamed cabbage for coronary artery bypass grafting. And this is another way of rerouting blood. Again, it does not take care of the problem. It just reroutes the blood so you have no symptoms, or prevents a heart attack. And what they do is they'll take veins out of the legs, and they'll take an artery off of the chest wall and reroute it, and just basically reroute the blood. If you imagine driving down the street and there's traffic, really heavy traffic on Forsyth, you take a little side road to get all the way around whatever wreck there was. That's all the bypass really is. Okay. As I said, that doesn't fix anything, so you do need to continue on medications. We put patients a lot of times on antiplatelet or anticoagulant medicines, cholesterol medicines, blood pressure medicines. Even if your blood pressure is normal, many times we put people on blood pressure medications. So again, warning signs of a heart attack: chest pain or discomfort. It can feel like a tightness. Pressure or squeezing can last for a few minutes or more. And it can also kind of stutter, or starts and stops and starts and stops, especially with exertion. Shortness of breath is very common with or without chest discomfort. The pain or the discomfort can extend to the neck, the jaw, the arm, back, sometimes the stomach. You can have other signs including cold sweating, nausea, feeling weak, lightheaded, faint, suddenly extremely tired. And if you have symptoms that you feel you're having a heart attack, obviously call 911. Don't drive yourself to the hospital. And you can learn more about stents from Medtronic.com, and the American Heart Association has lots and lots of tools to help you estimate your own personal individual risk and get more information. Thank you very much. May I have any questions?
So the stents and those kinds of medical procedures, the more aggressive ones, if you have, and you may not know this off the top of your head, but say you have a patient who receives a stent and they make no other lifestyle changes, what's the chances of them having another cardiac event afterwards?
That's a great question. And that really depends on all the risk factors. Some people have, quite a few risk factors, the genetic risk factors, the diabetes and high blood pressure, cholesterol, and those are not controlled as well. And you're very, very likely in that case to have further blockages in other areas. So even if you do the stent's perfect and that stays open, you can get other blockages in other areas.
And once you have these blockages in there, whether you have to have a procedure or not, do lose the weight or whatever, will those eventually get better? Or will it reverse in any way?
That's a really, really good, very difficult question. There is some data that some things, certain types of medications and certain lifestyle changes can reduce some plaque some. But they don't go all the way away. There is some evidence that they'll reduce some. The more important is if you have minor blockages, so not 99%, but you have 30 or 40 or 50% narrowings that aren't bad enough yet. The more important thing is to stop them from getting worse. So the exercise and the cholesterol medicines and all that good stuff, a lot of times will stabilize them so they don't progress. And that's really just as helpful as them going all the way away.
Yeah, when you said that, and I know that we see, not we, that the field sees more and more younger people with some of these risk factors, a lot of which are tied to lifestyle. Do you think there will come a point when we'll be diagnosing people in their teens? Meaning, like, are they going to be undergoing evaluation processes to determine how much blockage they may have already?
Not likely. All these tests have significant risks associated with them, and so we try to balance the risks of the test with the benefits. And so a lot of times we wait until people have symptoms, and we use other tools to assess risk and try to intervene medically before it gets there. Now, that being said, I've definitely seen younger and younger populations with heart disease, even people in their 20s. It is becoming younger and younger, a bigger problem.
Sure. We haven't talked a whole lot about triglycerides. Is that as well? If your triglycerides are decreasing, triglycerides are in another pump. They also add to those.
Yep.
Or whatever buildup.
Yep.
Plumbing buildup. So if you are lowering your triglycerides, that in addition will reduce your rate, or is that reduce your rate of something else?
No, that does. Triglycerides do play a part, absolutely. Yep.
Okay.
A lot of times the treatment for the LDL and the treatment for the general cholesterol will help the triglycerides. Sometimes if you have familial problems where your triglycerides are super, super high, you need other therapies. But in general, you kind of treat it all the same and it all comes down.
And other than fish oil, is there any other superfoods for LDL if you are trying to pick that up?
Well, the HDL, to raise the HDL, yeah. To raise the HDL, the best thing for that really is exercise. The fish oils do help a little bit, absolutely. Certain medications help that a little bit as well. But the evidence is not that strong that they prevent bad outcomes. So it may raise the number a little bit, but it doesn't necessarily translate to reducing heart attacks and deaths, things like that. The biggest thing is exercise. That will raise it more than anything else.
And I don't want to dominate, but I just want to ask the question.
Sure.
If you have a bradycardic heart where your resting heart rate is 40 or 50, is that going to affect that number?
Affect which number?
The cholesterol that you're trying to get better, your good cholesterol.
No. Even if your resting heart rate is low, as long as you can get your heart rate up when you exercise. If you're having trouble where you can't get your heart rate up when you exercise and you get out of breath and really weak when you're exercising, that may be another problem. But even athletes who have very low heart rates, they could be 40, 45, sometimes lower. When they exercise, their heart rate will still go up.
Right, it goes up. It's just that I'm trying to kick my good cholesterol up higher, and it's just, I get my heart rate up.
Yeah.
I'm just wondering if there's anything else that I can do to get the good cholesterol.
We don't know. We don't know. There have been several medications that have been tried. There's some medications that'll do it, like fibrates, that haven't really translated to better outcomes. There's a couple of different drugs that are in trials right now that do raise it substantially, but they've all had horrible, horrible side effects and had to be scrapped. And so, we've tried fish oil and that helps some, but again, not great evidence that it helps outcomes. So the best recommendation, even though it's sometimes not enough, is exercise. Good question.
What would you say if you had a patient come to you and they were concerned about their heart health? What would be the top 3 things that they could do, regardless of genetic risk factors?
So the first thing I would say is at least 30 minutes of continuous aerobic exercise 5 days a week, the Mediterranean diet, and not smoking.
There you go. It's so easy.
Thank you very much for having me.
Thank you very much.